50 and 90,000 new cases per year, and a mortality of between 10 and 20,000. Currently, with the decline of the incidence in South Asia due to a very ambitious Kala-Azar elimination program, the main hotspot is still in East Africa. So Sudan, South Sudan, Ethiopia, Kenya, and Uganda. A bit more about the disease. Talking about visible leishmaniasis in East Africa and South Asia, the parasite is the Leishmania donovani, which is transmitted by phlebotomon sandflies. These sandflies, they're only 2 or 3 millimeters small, and they take blood meals from humans in which they can transmit the parasites. For Leishmania donovani, transmission is anthroponotic, so that means that there is no intermediary animal reservoir, but there's direct transmission from one human to another human by the sandfly, and therefore also makes it possible to create outbreaks and large epidemics. VL is a systemic disease of the visceral organs. The Leishmania parasites, they multiply in the white blood cells, which are a very important factor in human immunity response system. And because they destroy the macrophages, those white blood cells, patients become severely immunocompromised. The signs and symptoms of the disease are quite non-specific. That is prolonged fever, weight loss, weakness, diarrhea, enlarged spleen and liver, severe anemia, nosebleeds, lack of appetite, etc. But what is more important is, due to the breakdown of the immune system, the patients are very susceptible to opportunistic infections like pneumonia, dysentery, malaria, TB, HIV, but also have other complications like severe anemia, malnutrition. Typically, visible leishmaniasis is fatal if not treated. The treatment is quite complicated. It is with toxic drugs. It is long, so at least 17 days, up to 1 month or even longer. Patients have to be hospitalized, and therefore treatment is expensive. But apart from treating the disease, a lot of focus is also on the treatment of the multiple complications. So the opportunistic infections, the anemia, which may require blood transfusion, severe malnutrition, and even organ failure. Here you see some typical children with very enlarged spleens. The boy in the middle, you all can also see the scarring on the spleen, on the skin, made by traditional healers, where people very often go first. And on the right, you see a table with all the visible leishmaniasis cases that have been treated by MSF since 1989. Totaling up to almost 150,000, and most of them treated in East Africa, so South Sudan, Sudan, and Ethiopia. Now, where we did this, sometimes in proper hospital settings, like in Bangladesh, but often also in very remote, isolated areas, like in northwestern Ethiopia, in field hospitals. But sometimes also just under the trees, like in South Sudan, when we have to respond to epidemics or outbreaks in very remote, isolated settings where there is no healthcare infrastructure, or also during times of active conflict, especially in the 90s. It was not possible to erect permanent structures because those could be seen by the planes of the Sudanese army, and then those locations would be bombed. So we were more or less hiding under the trees to treat those patients. Here, this typical scenery of South Sudan. On the left, you see the Nile, the River Nile, which during the rainy season results in the biggest swamp in the world, the size of France. A lot of acacia forests, which are the habitat of the sandfly, but yeah, a very poor health infrastructure with major physical barriers, especially during the rainy season, but also war and insecurity, which prohibit patients to access healthcare, during which also healthcare facilities are being destroyed, and a lot of population displacement. So very often we see that patients have to walk, or if they're too weak, they're brought on a makeshift stretcher, walking for several days to reach a small MSF hospital where VL can be treated. But also for aid workers themselves, the only way to access the endemic areas is by planes, and everything, not only the drugs and people, but also construction material, everything has to be transported by plane. So if we now talk about the diagnostic workup for visceral leishmaniasis, first we need a clinical case definition for suspicion, after which then we can do diagnostic confirmation. For a clinical suspicion case definition, we need a case definition which has a high sensitivity, because we use it in a screening context. We want to pick out as many cases as possible, but therefore we also have to compromise on specificity. So for the clinical case definition, we looked at the different signs and symptoms, and then we picked out those which were most common, like fever, weight loss, enlarged spleen, and enlarged lymph nodes. And therefore we came to a clinical case definition of a history of prolonged fever of 2 weeks or more, with splenomegaly and or enlarged lymph nodes and or weight loss or wasting. However, this clinical case definition only has results in a prevalence of VL within those suspects of between 20 and 50%, which means that between 50 and 80% of the patients that meet this clinical case definition have something else. They don't have Kala-Azar. So that makes it quite difficult, and therefore we also need a confirmation test, because there are many other differential diagnoses that present with similar clinical symptoms, like malaria, schistosomiasis, brucellosis, typhoid, TB, etc., etc. So it is on a clinical basis not possible to make a good diagnosis. So initially, what we had available was parasitological confirmation by doing a tissue aspirate, put that on a Giemsa stained smear, and look under a microscope to see if you can find the parasites. The easiest one is a lymph node aspirate, but this method lacks sensitivity. Only 50 or 80% of the disease cases will be picked up by this method. A bit more sensitive is bone marrow aspiration, but as you can imagine, you have to get tissue out of the bone, so you have to drill it, which is extremely painful. You need to be very careful with sterilization, and it's a very medical procedure. Still, the sensitivity is only moderate, with 70 to 80%. What we prefer to use is spleen aspirates, because that is the method, a bit of the gold standard for parasitological confirmation, 90% sensitivity, but it is a potentially riskful method, because there is a risk of splenic bleeding or even splenic rupture, which can be fatal. So it needs well-trained people and all kind of contraindications as well. But so that is not suitable in a remote field setting. Here you see, yeah, during the early 90s, how this method was used in the field in South Sudan. You also see a picture of a white blood cell with inside its several amastigotes of the parasite, and you can see the nucleus and kinetoplasts. A study that we did in Sudan showed that, yeah, lymph node aspirates, which was the only method that was allowed in Sudan, had a sensitivity of only 65%. And this method is very difficult to, it's quite laborious. So if you're in the middle of an outbreak, when you have dozens of patients presenting every day, this is yeah, a huge burden, and you may not have the capacity to do that. So therefore, when we started our operations in South Sudan, just 1 year before, a Sudanese scientist had developed a direct agglutination test, which is using the whole parasite as an antigen in a serological test. Which is very sensitive. It's well validated, but it is still quite technical. You need meticulous pipetting. The reading is not so easy. It needs more than 18 hours incubation, and it is quite expensive. In the beginning, we only had one only thing that was available, and it was produced by the Royal Tropical Institute in Amsterdam, was a liquid antigen, which is very sensitive to heat and to shock. So you needed a cold chain during transportation and storage, but also, yeah, when it was on bumpy flights, due to the shock, the antigen could also be destroyed. So it is possible, but it needs a lot of external support using this test in the field. Then in the mid-90s, also in collaboration with the World Tropical Institute, a freeze-dried antigen was used. And this was quite a solution because it was a more robust antigen, less sensitive to shock, didn't need cold chain, and therefore there was less wastage. So by trained lab technicians, this could be used in the field, and yeah, where you can do multiple tests at the same time. But still only possible in settings where you have a proper lab and lab technicians. Then in the early 90s, early 2000s, finally something came to the market that we all were waiting for. It was a serological rapid diagnostic test, which is simple, fast, and low cost. This is the INSPiRED test. It takes only a finger prick, blood, 1 drop, and some buffer. And it's a lateral flow test, which gives a result after 20 minutes at a cost of only €1.70. Because of the ease of the test, it can be used in the field, in the community, but also on the bedside. In the early 2000s, there were many different formats that were produced by different companies. Yeah, in order to find the best one, we did several field validation studies. Some of those tests, they lacked sensitivity. Other ones had major problems with specificity. But finally, we found the INSPiRED, which is currently produced by Biorad, is the best performing test with 90% sensitivity and 99% specificity in clinical suspects. We also did this a validation study in severely immunocompromised HIV patients, which is yeah, an important co-infection visceral leishmaniasis endemic areas, especially in northern Ethiopia, where up to 20% of visceral leishmaniasis patients are co-infected with HIV. And you can imagine that because of their immune suppression, they may not be able to produce sufficient antibodies to be picked up by the rapid diagnostic test. So we also validated here and indeed saw that the sensitivity in HIV co-infected patients was significantly reduced. So in the end, we came up with a diagnostic algorithm for visceral leishmaniasis in East Africa. So a patient who has who is a clinical suspect, so prolonged fever with splenomegaly or wasting, was then submitted to the RK39 rapid diagnostic tests. If positive, due to the high specificity, we can assume that the patient has Kala-Azar and can be treated. But because the test only has a sensitivity of between 85 and 90%, it means that you miss patients. And because it is a fatal disease, you want to pick up all patients. So therefore, you have to go through a backup diagnostic algorithm with first the direct agglutination test, which is a quantitative serological test with low titers. You can assume it's negative, high titers positive, but still you can have the intermediary titers or borderline titers, which you cannot make a conclusion, and those patients then have to go through aspirate microscopy. Also, because both the rapid diagnostic test and the DOT test are serological tests, and antibodies may persist in patients for many years after treatment, all patients with a history of visceral leishmaniasis directly had to be tested with aspirate microscopy. But what you see is that, most of this diagnostic algorithm requires a proper laboratory to perform the direct agglutination test and to do the smear microscopy. So that is still a handicap of this diagnostic algorithm. But still, the rapid diagnostic tests had a huge positive impact.
Good.
Here you see
2 minutes. If possible.
Okay, yeah. Here you see a map of Sudan and South Sudan in 2001, where treatment diagnosis could only be made in hospital settings, and at that time we only had 5. But thanks to the rapid diagnostic test, we could decentralize diagnosis and treatment to health center levels and even into the community. So this has had a major impact, positive impact on access to treatment. Here in Northwest Ethiopia, where until 2003 we could only do diagnosis in a hospital setting, and once we had introduced the rapid diagnostic tests, we could decentralize, which had a major impact on improved access to treatment. And then you also see a huge impact on reducing mortality, because early diagnosis and treatment saved a lot of lives. Several other tests that were in development have been studied, antigen detection tests, which are preferred over serological tests, but the only test so far is a urine test, which has low or moderate sensitivity and moderate to high specificity, so still not useful in the field. FIND is trying to develop a format with increased sensitivity, but so far unsuccessful. I will leave out the loop-mediated, so the low-tech PCR, because molecular diagnostic is something that Michelle will talk about. But this is actually what we need. A patient with fever can be tested with an antigen detection rapid diagnostic tests, which will allow us to diagnose both primary and relapse visceral leishmaniasis, but also to assess treatment efficacy. So far, it looks a bit like science fiction, but we still hope that at some point such a test will be developed. And finally, yeah, despite all the constraints and working under the trees at the moment, if you look at the field lab in South Sudan, looks like yeah, proper lab with an air-conditioned room where we can do electrolytes, hematology, CD4 counts, gene expert machine to diagnose TB, a blood bank, etc. So, but still, we are looking for this silver bullet test for visceral leishmaniasis. Thank you.